Well, good morning, everyone. I think we should get started. It's so great to have everybody here and all the great conversations happening. So I hate to have that part of the morning end, but the beginning of this next part is really the reason that we're here. I'm Lori Bergen, and I'm the Dean of the Diedrich College of Communication at Marquette. And I'm so delighted to welcome all of you to our second annual O'Brien Fellowship in Public Service Journalism Conference. This is a really great day to celebrate and to look around the room and to see so many familiar faces and faces that have become so familiar to us because of their time spent with us this last year as O'Brien Fellows. I want to take just a minute to reflect on where we've come and what we've built here. And it's really a spectacular model, I think, for the kind of journalism that will sustain our civic and democratic society in the future. It's a unique partnership between benefactors, between an institution, a university institution, and a media institution in our community. And I think what we've created here is something that can serve as a model for the ways that journalism can continue to be central to our democratic society. So I want to take just a minute to recognize our delightful benefactors, Peter and Patricia Frechette, who are at the front table here. Thank you so much for your vision to allow this to happen, for always being so much a part of this too, and for coming to join us today. So please, a round of applause and our thanks to you for everything you've done to make this possible. I also want to thank Herb Lowe and our faculty and our students who've worked in so many ways on the Marquette end of this project to make everything happen. Really grateful for all the work that Herb does and his great group of students, just the amazing capacity to bring together professional journalists with journalism students. We've really created a new model for journalism and for journalism education. And I also want to thank our partners from the Journal Sentinel. I know that not all of them are here yet, but we've had a really great opportunity to be partners with them to help to create the space where all of this magic is happening. And to our O'Brien Fellows, whom you will hear from, our delightful guests from last year, Lily and Hal and Dan, who are going to be sharing the results of their work over the last year, and also the chance to meet the O'Brien Fellows who are with us now and who will present a year from now, Brandon and Marjorie and Raquel. So to all of the O'Brien Fellows, give a wave so we know where you all are, and welcome and thank you. We're so glad that you're all here. I want to just really now reflect for a moment on what it has meant for me and for our college to be able to be involved with this project. In many ways, we've created something here that it's a highlight of journalism education for our students. And while they built their skills and they prepared to be partnered with our O'Brien Fellows every year, what they also get to do is they get to spend their following summer at the home media organization of each of our fellows. And that capstone experience, you'll hear from our fellows and you will hear from our interns just how transformational this has been. And with a partnership with Marquette in its Jesuit tradition, I think there's no better way for us to be preparing students to truly pursue through their profession and their vocation the opportunities to make the world a better place. That social justice mission is central to all of this. And so we are the best place for this to happen, and I'm so grateful that our colleagues, that our donors could all come together to make this a possibility and now a reality. So I would like to introduce Lillian Thomas from the Pittsburgh Post-Gazette, from the inaugural class of O'Brien Fellows, and her presentation this morning about healthcare is really will be amazing. So Lily, please join me and come from that end, or else you're going to have to leap up onto the stage. So thank you all very much.
Good morning. It's great to be here, and I'm glad you all came. I'm happy to be back in Milwaukee. I'm staying in the Knickerbocker, which is where I lived last year, which is right on the lake, and the lake was really one of my favorite things about Milwaukee. When I got the invitation for the date for the conference, I realized that 1 year ago to the day, I was not only in Milwaukee, but I was very sad because The Pirates had just been bounced out of the postseason. And 1 week and 1 day ago, the Pirates were bounced out of the 2014 postseason. So all I can say is, at least I'm not a Brewers fan. Okay, no more on that. This presentation is about the series I did as an O'Brien Fellow, and the story I wanted to tell in the Poor Health series was a story of the challenges that low-income people face in getting health care and in attaining good health. This was not something I had ever experienced, but I had an experience about 15 years ago that kept coming back to me as I did the reporting and talked to many, many people. That was a night in Hungary in Budapest. I was visiting my brother and was with my parents, and we drove around in a cab because my father he had congestive heart failure. He was gasping for air. We were trying to find medical help. And we didn't speak the language. We got dumped off at a giant slab of a building. We couldn't get in the first door we went to. We were wandering down hallways. And it was a frightening, disorienting experience. He did ultimately get good care, but I think that kept coming back to me because I was talking to so many people for whom healthcare in the United States can be that disorienting and that difficult to navigate, that it really does feel like a foreign country. So, if I can move my slides here. The genesis of this project came about 5 years ago when the healthcare giant in the Pittsburgh area, which is University of Pittsburgh Medical Center, called UPMC, bought Braddock Hospital. Braddock is a steel town just outside of Pittsburgh, and about 30 years ago, it was a bustling, wealthy, prosperous town. Not wealthy, but steel workers were making good living. When the steel industry collapsed in Pittsburgh, Braddock and all the little towns like it on the Monongahela River also collapsed. Now Braddock has high crime, high unemployment, a lot of poverty, and very few institutions left. One of the few institutions that was left was Braddock Hospital, which was really not only a medical center to the community, it was kind of a community institution. Because Braddock actually has no restaurants left, the cafeteria in that hospital was where people in the community would go to eat and to meet. So it was more than just a hospital in that town. And although when UPMC bought Braddock Hospital, they said they were going to refurbish it and make it a viable institution, economic conditions changed, and in 2011, they announced that they were going to close the hospital. And despite lots and lots of protests from people in the community, from political leaders, lawsuits, a lot of resistance, UPMC did indeed tear Braddock Hospital down. And we at the Post-Gazette, which is my paper in Pittsburgh, did a lot of reporting on this, obviously. It was a big story. And the core question of how this giant $5 billion entity, UPMC, could not find a way to fund this hospital in a poor community was really at the core of what I wanted to do in this project. And so when I got the opportunity to come to Milwaukee, I thought I could take that experience and see whether it was true in other communities, but also really try to understand it, try to understand what the forces were that made UPMC make that decision. So when I got to Milwaukee, I started doing some reporting here to see if similar things had happened in Milwaukee. And indeed, as I'm sure anybody who lives here knows, many hospitals in the inner city, in the north side, in the poor areas, have closed down in Milwaukee over the past several decades. And so I started working with the journal Sentinel, and I have to say, I'll just give a plug to the fellowship and to the journal Sentinel. One of the best things about this fellowship was having this instant group of colleagues who were helpful and super good and fun to work with. So I met Greg Borowski, who is the editor who helped me with my project, and he put together a team for me, including a great data reporter. And we started gathering data just to try to find out where hospital closures were, had this happened across the country. And even though Kevin is a crackerjack data reporter, we started joking about 3 months in that Kevin's problem was he kept getting people fired. This is an email chain, which you can't really read, but Kevin kept writing to people at CMS and other federal agencies. He kept writing to people, and then he wouldn't hear back, and he'd call or write, and they would say, oh, that person doesn't work here anymore. Give him a new person to write to. And this went on and on. He kept having difficulties actually pinning down people and getting the data information. He eventually did get that data information, but that was part of his struggle reporting. And part of my challenge in reporting this story was, even as we were getting lots of data and I was talking to lots of experts, lots of doctors, lots of healthcare providers, I knew, and any reporter in this room knows what this is like, I knew I needed a real person, what we call a real person. I needed a face for this story to be able to show people and tell people and have a voice of someone who was facing these struggles that I was finding when I talked to people in poor communities. So I spent a lot of time hanging out at free clinics, often in basements of churches and other places, including that abandoned hospital. And I met some really wonderful people in those, the people who run them and the people who are at those clinics. And one is a gentleman who you're going to meet later, and he is sitting right over there, John Patton. And I met him at City on a Hill, which is a nonprofit that runs a small clinic once a month. They're trying to bump it up to twice a month now, I think. And he was hanging out, waiting in chairs to get some free eyeglasses. They have a glasses clinic once every 2 months, and he seemed to really be enjoying himself and making other people feel comfortable. So I chased after him, and we talked in the hallway for a while, and I asked if I could just follow him and see what he was facing as he sought treatment for a whole series of medical problems that he's had over the years. And again, we're going to hear from him, so I'm not going to talk too much. I'll let him tell you about himself. But that was a great moment, and also something that really made the city special, because I felt like I'd made a friend as well as found a great contact. The other piece that we were trying to do, going back to the research part, was finding out not only where hospitals were closing, but where they were opening. Because often when hospitals were closed, the reason given was that outpatient care was replacing inpatient care, and that hospitals were consolidating, closing, and merging all over the place, and that this was just a reflection of economic reality. And as anybody who has had an outpatient treatment that 15 years ago would have been inpatient knows, this is true. There are fewer need for inpatient services because so many things go outpatient. But we did find in our research that new facilities were being built. And in fact, in Pittsburgh, at the same time they were tearing down Braddock Hospital, literally the same time they were starting a new hospital, a shiny new hospital, which, as you can see, really is shiny, in an affluent suburb to the east of Pittsburgh called Monroeville. And that suburb already had a hospital from a competitor. So they were opening and expanding in an area that was affluent, that already had health care, while they were shutting down in an area that didn't. And that was something that we, again, wanted to document, that it was going on all over the country, and we're able to do so. Another great part about the fellowship was the chance to work with Marquette staff and students. And some of the students who worked with me are here today. Kara, whose work I'm going to put up here, is not. She's studying in England. But she worked with me for both the semesters that I was here, and took a class with Daria Kempka, who's also here, and learned a lot of coding and learned how to make interactives, and did a very cool interactive on the history of the hospital that became City on a Hill, the nonprofit where I met John. So we kind of had this nice confluence where I wanted to tell essentially the biography of a hospital. In addition to the biography of a person who was facing these challenges, I wanted to tell the story of a hospital that had been created more than 150 years ago as a nonprofit, purely charitable organization. And as many of you probably know, back in the day, hospitals were places you didn't want to go. Only poor people went to the hospital, and wealthy people didn't want to be near them because they were considered sources of contagion. And in fact, this hospital, when it was going to expand in the 1860s, I believe, was burned to the ground because people were strongly opposed to it. But the little Lutheran deaconesses persisted and rebuilt and expanded. And the hospital that went by various names, including Lutheran Hospital, Milwaukee Hospital, Good Samaritan, Sinai Samaritan, and ultimately became the West Campus of Aurora Sinai. That hospital continued to grow and grow, and the neighborhood around it, which had once been this rural area, was started in a farmhouse, was in the midst of a very low-income neighborhood on the Milwaukee's north side. And in 1998, that hospital was closed, merged. It had already been merged, and it was closed down. And that full circle of going from an institution that had begun to serve the poor and that in more recent years was occupied by this little nonprofit, which also had a clinic to serve the poor, kind of appealed to me because I thought it was interesting that it had ended its mission the way, or is continuing the mission that it started, but in the meantime, it reflected that whole economic change of American healthcare and American hospitals. Meanwhile, back at the journal Sentinel, Kevin finally got all his data, and Kevin and Alan Vestal and several other people put it together in this really extraordinary series of maps. And they had done this before, but this allowed us to show our readers and let them look in their own city, because we did the top 52 metropolitan areas. And in each case, we outlined or showed by census tract the poverty corridors in the given city. We showed where hospitals had closed and where they'd opened. We showed the income levels and the rates of disability, which was a reflection of the underlying health of communities. And we showed where there were physician shortages. That's a federal measure in which certain communities are designated shortage areas, meaning they don't have enough physicians to serve the population. And this really allowed us in an interactive and accessible way to show the findings, and that became the data backbone for my series. I wanted to tell the stories, but I also wanted to be able to say that these weren't just anecdotes, that this was something that could be confirmed. Another thing that I started understanding a little better as I continued reporting was something that in the social science jargon is social determinants of health. And simply put, that means being poor makes you sick. That it's not just that poor people don't have access to a hospital, because many times poor people do have a hospital close by or close enough. Many times there are clinics. But there are other aspects of poverty that impair their health. And that can be anything from language difficulties to something as basic as poor water, contaminated environment, mold in an apartment, and malnutrition. So all of those things can contribute to poor health. And so even if a person who lives in poverty gets good health care, goes to the hospital, has an emergency, goes to the emergency room, gets great care, they go back to the same environment that had caused them to be sick. And they also are less likely to get preventive care, they are less likely to have primary care physicians, they are less likely to catch things early on and instead wait until they're very sick to go to the hospital. So all of those things were another piece of this story I was trying to tell, that it wasn't just on the side of medical care, that it wasn't just lack of availability, that it also had to do with poverty itself. And this is often presented as a fairly new thing, but I was talking to this 88-year-old doctor, Jack Geiger, who's really a great and wonderful person, and he told me that he believed in the 1950s, when he was going to medical school in Cleveland, that he had invented social determinants of health. He said he looked out and saw poverty and had this beatific vision that poverty itself was a factor in poor health. And then he did some research and found that in 1790, Johann Peter Frank had written this big treatise saying exactly that poverty itself is a problem in poor health. And this is Dr. Geiger. This is actually back in the day when he was young in the 1960s. He created 2 clinics, one in Massachusetts and one in rural Mississippi. And he really wanted to put in practice the concept that if you addressed those social issues, you could improve health care. So he opened this little clinic in Mississippi, and if the people were drinking water out of drainage dishes, which they were because they didn't have clean water, he and his team would help them dig wells. If the people were malnourished, which they were, he would write prescriptions for food, and his clinic would pay the local grocery stores for people to get food. And he told me that he got in trouble with the government for that because they said, "Why are you writing prescriptions for food?" And he said that his reply was that the last he heard, food was the best antidote for malnutrition. So he was not to be deterred. And he is considered the father of federally qualified health centers because his concept spread all over the country, and FQHCs, as they're called, are now clinics. There are, I think, almost 5,000 all over the country. And they were all based on that same principle. But over the years, because funding began to decrease, the social part of that, the attention to social issues decreased, and they became, by necessity of lack of funding, less able to deliver that. But I found that it was interesting that people now were asking these questions when this model already existed. And so I wanted to write about that too, that we have a model in place that could address these issues. We just haven't used it and funded it in the way that we could have. The third installment of the series looked at some of the solutions, including the FQs, but also some things that are being done in the broader healthcare area, including a statewide experiment in Oregon in which they are trying to change the way Medicaid is delivered using some principles that are really based on some of the same things that I was writing about. So why an air conditioner? The classic story that Janet Meyer, who heads one of the agencies in Oregon that is pioneering these efforts, a story she told us was that they had a patient who had respiratory problems and was having difficulties and kept going back to the emergency room over and over. He would get sick, have trouble breathing, go to the ER, be treated, stabilized, and then go back home. And then she told me, we come to find out he lives in a 4-story walk-up. He doesn't have an air conditioner. He's not managing his fluids well. And she said, we thought, what if we just spent a couple $100 buying him an air conditioner, hire a community health worker, that is Lisa Perlman, who was another person who allowed me to follow her around in her rounds in Oregon, and have that person help them manage their medications, manage their fluids, and keep this person healthy enough that he doesn't have to go to the ER. So you actually save money and you're doing better health care, which is this like genius idea that doesn't really seem that it could be true, but it seems that it is true, that not always, but in many cases, there are things you can do to stop people from getting sick before they get so sick that they're very expensive to treat. And I found a similar program in Philadelphia in which people in the community are recruited to serve as outpatient and healthcare workers who work directly with people after they're discharged from the hospital and help them manage their aftercare treatment and, again, have the professor who started this program has done a lot of studies on it and has found it really drastically reduces readmissions to the hospital. So I'm going to leave with that and just show you, because Herb wanted me to show you what this series actually looked like in print. The series was published by both my paper, the Post-Gazette, and the journal Sentinel, and that was another great aspect of this, was the collaboration that both papers got to use to combine their resources, but also got to run a series that we thought was of interest to both communities, because I had done lots of reporting from Milwaukee. Those stories were clearly of interest here, but I think that they worked because we had the national data, so that we got great feedback in Pittsburgh as well. The second part of the series was based in Pittsburgh, and we actually went back and revisited Braddock to see how things had gone along after Braddock Hospital was closed, and the answer was not too well. But this is just to give you an idea of what it looked like on the page. There's John. And there's the last series. We showed a whole bunch of hospitals being torn down, just to put across that point. And we were following people in clinics here. So I am now, I think, about out of time, but I'm happy to take questions. Yes, Lori.
I just wanted to ask you to speak a bit more about the data collection process and the creation of the national database that you use to provide the foundation for your reporting.
Sure. We started with income numbers to be able to define poverty corridors in the major cities, to be able to show where the poor people live. And that's pretty basic, and that was not a problem. Then we were collecting data from CMS, from the Centers for, they collect data on diseases, disability, and we use that data to try to map out by census again where people have disabilities. And it's hard to measure health overall, because we knew that diabetes was higher in poor income neighborhoods. We knew that many diseases are higher, hypertension, but it was hard to sort of have a measure of overall health. And we use disability just because if you get disability, that means your health is significantly impaired. So it was a stand-in for a rough measure of health. And we found very significant differences in affluent and poor neighborhoods in terms of the percentage of disabilities. In some poor neighborhoods, it was as high as 25% of the people were on some form of disability. And then the other information we got was hospital closures and openings, and that, again, was partly government data and partly from hospital associations. And Kevin had to go and verify every location and to make sure that a hospital that was listed as closed hadn't simply been merged and still existed. So it was a very time-consuming process to verify. There's one back there, and then I think you're next.
So lots of people know about the importance of access to quality health care and individual health behaviors in determining whether a person is healthy or not. But this concept that being poor makes you sick, and for reasons you mentioned and also due to chronic stress and changes in stress hormones, et cetera, is one that's very difficult for a lot of people to wrap their heads around. What kind of challenges did you have in communicating that concept, and how did you address those challenges?
That's very true and a very good question. often when I was talking about barriers to health care, I would get the response of, this person lives a mile from a great hospital. This person has a clinic in their neighborhood. They can sign up. There are programs out there. What really is preventing them from getting good health? And I think that was the challenge. I think trying to follow individual people and talk to doctors about the difficulty when you have a patient who doesn't have a cell phone, might not have a stable address, might not be able to pay for the meds, even though you give them free samples, they don't come back. They might have violence in their homes. So I think that the best way I could try to address it was in those individual stories, to try to show an example of someone who wasn't getting the health care they needed, not because it didn't exist in their area, but because the circumstances of their life kept them from getting there, or if they got the treatment, it was on a one-time basis. They were they were discharged back on the street, but they didn't have the follow-up care that they needed to stay healthy. I think you had a question?
I got the impression that when you talked briefly about the Oregon system, that you were more impressed with that system than you may have been with other systems. Did you in your study find certain systems that worked a great deal more effectively than others, and what were the differences?
Absolutely. And it was interesting, too, because when I talked to both health economists and people in healthcare, a lot of people did feel that the system is moving ever so slowly in the direction of focusing more on outcomes. One of the things I tried to describe in this series was how the economics of healthcare puts the emphasis on procedures, tests, because that's what places are reimbursed for. That's what hospitals are reimbursed for. So I would talk to a doctor and he would say, I can get reimbursed for this and for this, but I can't get reimbursed for a 45-minute conversation with someone about how to manage diabetes. And so what they're doing in Oregon and in a number of other systems, including Philadelphia, is trying to flip that scenario so you are paid, you have the incentive to do that preventive care, that talking, all of the basic things, or to pay people to help people in their homes, all of those things that can keep people from getting very sick. And so, yes, I think that there are many good examples out there, and I think that the Affordable Care Act, in focusing on outcomes, is also pushing in that direction, ever so slowly, but I think that is where it's headed.
Lily, I wondered if you got any response from healthcare industry, trade associations, or nonprofit hospital groups, and I wondered if state or county officials, if they responded in any way, or did they say they were going to try and
Well, I know the Journal Sentinel got a response from some of the healthcare systems I'd worked with in the form of coming into their office and complaining about the stories, so I got that. But I did also get a response, and in fact, there's a very informal group of doctors in Pittsburgh who are trying to figure out how they can do some of these things in the community. They are people who are working within the system in which we have a dominant healthcare provider who want to figure out ways to better serve poor. A friend of mine is a psychiatrist, and he's worked in one of the poor areas of Pittsburgh for many years. So I did hear from them, and they wanted to talk to me about their plans and about other stories. So that's mostly what I've gotten, is some people trying to do the same thing.
And local readers?
A lot of very positive response, I think. We did get some letters and comments, and as commenters are always want to do, there's commenters saying what we were discussing, why this isn't really a problem. People can just get themselves to the hospital.
So Lily, we are going to queue up the chronic diabetes page, and if you could talk about that and a little bit more about how you and why you brought this together with student in classes, so they can scroll through for her.
one of my neighbors at Marquette was Sharon McGowan, who is head of the Milwaukee Neighborhood News Service. And she and I just got to be friends from being across the hall from each other. And I liked what her news service is doing. She also focuses on low-income neighborhoods, so we had something in common from the start. And we wanted it to be a collaborative process, and I knew Sharon was a good journalist and was used to working with students, so I thought, I know, I can have Sharon do some of the heavy lifting here on this project by working with students and her staff to come up with a local look at a particular disease. As I said, we were trying to look more broadly at health, but we decided to focus in Milwaukee on diabetes. And Sharon and her staff and Daria, who's also here, and her class of students worked together to both produce the reporting, and then the students worked to create the interactive that appeared on the Neighborhood News Services webpage. They're an online-only publication. And they did just this really cool interactive that the students did most of the research on their own and did all of the technical stuff. So it was a very rewarding experience. And again, another very unusual part of the O'Brien Fellowship is that collaboration. And they were open. This was just something we came up with. It wasn't written into the script of what we were supposed to do in the year. But it just seemed to me to be an opportunity to do something that would benefit my project, but that also would benefit the local area.
It seems your group did a very sophisticated investigation as to what's going on the hospital side with respect to closures and building of new hospitals. And I suspect that if you were to look at physician practices, whether those be independent practices or hospital-owned or affiliated practices, you would see some of the same movement from the poor areas to the affluent areas. It's been discussed to a great extent in the U.S. with respect to the payment mechanism. Did you consider what was going on there and whether healthcare, at least the basic healthcare, needs to be the third public service similar to fire or police?
Yes, we did. And that was partly captured in our data in the physician shortage, because the physician shortage areas indicates that there's not enough people. And we also had quite a few people, experts, who had done studies saying that when the hospital leaves, obviously the physicians leave because their practice, either they are employed by or they practice at a hospital. So it's not just the loss of that bricks and mortar. You often lose the people, and the same reasons. There's economics push people towards specialization anyway, so there are fewer primary care. And then the primary care physicians who are there have their own economic reasons not to want to practice in poor neighborhoods. So that was partly captured in the series. But you are correct that if it's not viewed that way, it's hard to spread those services out. They won't, on their own, spread out that way. And one of the great quotes that I got in the series was someone saying having hospitals across the street from each other competing was like having competing fire stations. It was this idea that it should be a public service, and it's ridiculous for them to be operating as if they are businesses as opposed to operating as if they are a service. Anything else? Well, thank you so much. Thanks for being here. And I'll step down and let Herb take over now.